Thank you, and thank you to the organizers and to those of you who endured through the full conference. It's really a pleasure to be able to present truly hot off the press data from our pilot that Ruan described yesterday. And this is presenting the data on viral load impact of home-based testing and linkages to care in KwaZulu-Natal. So just to frame this, first, this meeting has reminded us all about the very strong evidence for prevention benefits of ART ranging from ecological, observational, and RCT data. But as we start thinking about moving from efficacy data to really evaluating effectiveness, I think we need to continue to remind ourselves that really it's coverage that really matters. Coverage at each step, HIV testing, CD4 testing, linkage to care, ART uptake, and sustained adherence, achieving viral suppression. And to know whether this is having a population-level impact, ultimately we want to measure infectiousness, which you can either do through population incidence or as a surrogate, decrease viral load, but measured at the population level. Many studies that report on community viral load are clinic-based and thus are biased in terms of measuring viral load among those who are retained in care. And a better measure, but more difficult, is to really measure viral load in the context of ART delivery, ideally at a community level. Yesterday, Ruan presented on home-based testing, and I want to just address a little bit about our thinking about where this fits in terms of the testing and linkage to care. And that I think building on the experience in Uganda, and I want to acknowledge John O'Merman for funding, I think, perhaps the first large-scale home-based testing study in the mid-2000s in rural southwestern Uganda. It was clear, I think, from that very first study that was done on a relatively shoestring budget that you could really reach a large number of people and you could rapidly scale up and get high knowledge of HIV testing. So building on that experience, which has now been replicated in multiple diverse districts in Uganda, we were wanting to go beyond just using home-based testing as a way to help people learn their status, to see whether you could actually link people to care. And through NIH funding and a PEPFAR supplement, we've had the pleasure of working both in Uganda and KwaZulu-Natal, not about 3 hours from where Till described, Africa Center, to evaluate home-based testing as a platform for facilitated linkages to care. We'll come back to this perhaps later in the question and answer, and I just want to underscore that we don't feel that this is necessarily the strategy for all settings, but in high prevalence settings, it's an effective way to get high knowledge, but you still are probably going to have to implement other strategies, particularly to identify men and younger persons who are not easily found at home. In our view, and I think the modeling supports this, is that if you do this once and you get a very high coverage level, you may not need to do it annually. It could be something that would be done perhaps every 3 or 4 years to identify newly infected persons and those who in-migrate. So with that background, we had a NIH grant, a PEPFAR supplement to our NIH combination prevention grant to implement home-based testing in a rural area of KwaZulu-Natal. And it was a 1-year supplement, so we had to do this very quickly. So in about a 6-month period of time, we implemented a protocol, including training, using lay counselors with the idea that if this works, we would transfer this to an already existing cadre of workers, community health workers in South Africa. We, just through informative discussions with people, it became clear that a barrier was in a place with a high unemployment rate is to get the transport money to go to a clinic to get your CD4 count and then go back for results. So we decided to implement point-of-care CD4 testing in the home for HIV positive persons. And as Ruan described yesterday, that ended up being very tightly correlated with flow-based flow cytometry performed in the lab. Our facilitated referral to care was fairly simple. Again, we're trying to focus on simple, scalable approaches. So we provided HIV-infected persons with a card that showed their point-of-care CD4 results. And we did a simple symptom review to find out if they had either STI symptoms or TB symptoms, and that was also noted on the card. And then they were given options of where they could go in this area. During the time when we implemented this study, we started where the CD4 counts were less than 200 as the South African national guidelines. But in the fall, they announced that they were moving to 350, and some clinics moved earlier than others to implement earlier ART initiation at CD4 of 350. We did follow-up visits by the lay counselor at 1, 3, and 6 months, and that was just completed in March, in late February, and so the viral load data had been finalized, and that's what I'll report today. To remind you, where we're working is a very rural area in KwaZulu-Natal, an area with about 400,000 people, very high rates of unemployment, with men having to travel far sometimes for employment. High HIV prevalence in antenatal clinics, and as Capriso 4 soberingly reminded us, very high incidence, 9% in the placebo arm in young women. We partly chose to work in this area based on encouraging experiences with the Project Accept. For those who don't know it, is a community mobilization for HIV testing, and to assess it, they were one of the 5 sites in Vulindlela. And they went they randomly selected homes and did an interview and obtained blood for testing, and had very high willingness, over 90%, for someone to come in the home and do testing. So it wasn't really a home-based testing service delivery model, but it was encouraging that maybe coming to people's homes would be acceptable. As Ruanne described yesterday, we did this with consent because we were collecting data. And I'm going to just focus on this part of our service delivery, where for those who are identified as HIV positive, we provided post-test counseling, obtained a CD4 test with point-of-care testing, as well as by flow cytometry, which was done in the lab. We referred them to care, and they had choices of where they would go, and then we did the follow-up visits. And just in a pictorial fashion, to give you a flavor of the teams that are doing this work, generally young lay counselors and a couple of recently graduated nurses who, after a community mobilization team, go house to house to find out if someone's willing to have testing. They go to the house and do an interview, do the rapid testing, and if positive, then they do the point-of-care CD4 testing. And they've just been a terrific team to work with. We measured viral load both at baseline and at 6 months using the nucleosynth assay, and performed and analyzed the viral load both in terms of mean viral load, comparing the baseline in 6 months with a paired t-test, and then the proportion with viral load suppression less than 1,000 copies by the McNemer's test. And as Christophe Fraser talked about on Monday, as we think about metrics for treatment as prevention, really what we're probably most interested in is the proportion who achieve suppression of viral load. And you could quibble about should it be less than 400 as we measure in clinics here, but probably based on Quinn's data and our data, in terms of transmission potential, the cutoff of 1,000 might be reasonable to use. So that's how we dichotomized our viral suppression data. So again, this was a pilot because we didn't know if this was going to be acceptable or work. We approached almost 300 households, enumerated a little over 700 adults, and of those, 673 were agreed to be tested, and we had a sobering prevalence of 30% of the households. This is an effective way to reach people at a higher CD4 count. The median CD4 count was 425. A third had CD4 of less than 350. About a third of all the 201 that we identified were on ART at enrollment, and so a sobering small proportion of those who had CD4 less than 200 were on treatment. So we had 6 people that did not make it to the 6-month visits because of death or loss to follow-up. Among the remaining, a remarkable 95% visited a clinic within 6 months, and we think that part of it is this point-of-care CD4 count that really motivated people to get into care. And in terms of ART initiation, overall, among those that were not on ART at enrollment, a quarter initiated ART, 85% of those who had CD4 less than 200. I think as you hear the viral load data, I just want to show the Kaplan-Meier curve so you can see that there was almost 70% visited the HIV clinic and initiated ART within 1 month, and then there's another little over 20% who initiated ART by 3 months. So the uptake was fast, but when you think about viral suppression, there are a proportion of people who are going to be still in the viral decline because they've only been on treatment for less than 3 months. So now focusing on the results, and among all HIV positive persons, for the 196 for whom we have samples both at baseline and at 6 months, we saw about a third, a 0.3 log reduction. However, if you exclude those who were on ART at baseline, it was about a half log reduction. So a significant reduction even within this relatively short follow-up. If you now stratify by CD4 count and using the former South African guidelines of CD4 less than 200 for ART and exclude those who are on ART at baseline, we had over a 3 log reduction. And among those who had a CD4 less than 350 at baseline and excluding those that were on ART at baseline, we had a little over a log reduction. But again, reminding you that some of these people were just initiating ART as the South African guidelines changed, so only partially suppressed, presumably. And then using the metric that Christoph proposed of less than 1,000 as our criteria for viral suppression, among those who had a baseline CD4 of less than 200, we went from 13% with viral suppression to 80%, and among those who had a baseline CD4 less than 350, it went from 35% to 63%. So in summary, I think you can say that the uptake was high and ART linkages were effective and were associated with significant decreased mean viral load and increased proportion of suppression among overall and among those with CD4 less than 200 not on ART at baseline and among those with CD4 less than 350. So in summary, in this small pilot in KwaZulu-Natal, rural KwaZulu-Natal, we were able to achieve a little over 90% uptake of HIV testing among adults that were enumerated, and similar proportion were linked to care in a setting where the HIV prevalence was 30%. The mean viral load decreased significantly, both overall and among those that were eligible for ART guidelines, which changed during the study. And we also saw a significant increase in the proportion with viral suppression. We're currently in an ongoing evaluation of a larger evaluation, both in rural southwestern Uganda and the same area in KwaZulu-Natal, where we'll have a larger sample size, longer follow-up, as well as we'll measure community viral load truly in the community outside of those that are reached through home-based testing. I just want to acknowledge it's been a really rich and productive collaboration with many people. I'm not telling you about other parts of the combination prevention package, but just focusing on the home-based testing and linkage to care. And we've really appreciated our collaborations in Uganda and South Africa. So thank you very much.